So I'm giving the next talk on humerus fractures. Now, obviously it's a very big topic, right? Each one individually can take up to an hour. So I have the impossible task of going over them in 45 minutes. So I skipped over humeral shaft fractures, not because it's not important, but given that the distal humerus talk that I gave a couple months ago took an hour in and of itself, I just had to cut back on a lot. So today I'm just going to go over proximal humerus fractures and distal humerus fractures because I think there's a little bit more questions about like when to treat them, how to treat them, exact surgical techniques, especially with distal humerus fractures. There's been a lot written about them in terms of fixation and complications. So we'll dive right in. I have no financial disclosures, conflict of interest. Let's start at the very top, the proximal humerus fractures. So obviously we're going to review bony anatomy first. So understand the overall alignment of the proximal humerus relative to the rest of the humerus. The neck shaft angle is 135 degrees, and the humeral head is oriented in 30 degrees of retroversion to face towards a glenoid, right? Because the glenoid is oriented 30 degrees anteverted relative to the body. When we talk about bony anatomy, we talk about multiple parts. So the greater tuberosity, lesser tuberosity, humeral head, and metaphysis, right? Understand that there's a difference between the anatomical neck versus the surgical neck, right? The fracture pattern we typically see involves the surgical neck, but you have to understand that anatomical neck fractures are a bad player. In terms of soft tissue anatomy, the attachments to the proximal humerus consist of the rotator cuffs, as well as the latissimus, the pectoralis major muscles. Okay? The importance of understanding where these attach really has to do with how the fracture behaves. So we talk about fracture behavior, right? And fracture behavior has to do with the soft tissue attachments acting on those various fragments. So on the lesser tuberosity, we have the subscapularis. On the greater tuberosity, we have the supraspinatus, infraspinatus, and the teres minor. Okay, so when you have, for example, a fracture involving all the tuberosities, your greater tuberosity will tend to migrate superiorly and go into external rotation. Your lesser tuberosity will tend to go to internal rotation and migrate medially. Same with your shaft, right? Because your pec and your lat are acting on the shaft, right? It's going to shift medially. Okay? And the humeral head can either go into varus or valgus alignment depending on direction of the force. It's also important to note the vascular anatomy. So the proximal humerus is supplied by the circumflex arteries off the axillary, both the anterior and the posterior. Now, which is the dominant supply? Which is the one that we actually care about? Well, that depends on which study you read. Traditionally, we thought it was the anterior circumflex artery. Okay. In more recent literature, back about 10 years ago, they did another study. They showed that actually the posterior circumflex has greater than 60% in the blood supply, but it probably isn't so much relevant. The more important thing to understand is that off the circumflex arteries, you have the arcuate arteries, which then supply into the humeral head, right? So if you have a fracture right at the anatomical neck, like I said before, that's going to cut off the blood supply from the arcuate arteries off the circumflexes. So anatomic neck fractures, as opposed to surgical neck fractures, have a high rate of AVN. Okay. In terms of neuroanatomy, understand that your brachial plexus is medial to your strap muscles, right? The coracobrachialis, okay? And also understand that the axillary nerve is off the posterior cord. It wraps around the posterior aspect of the proximal humerus and innervates both the anterior deltoid, the superior branch supplies the anterior deltoid, and the inferior branch supplies the lateral skin. Okay. So, and we'll get to this in a little bit later when we do our deltoid split approach, you have to be worried that the axillary nerve, these branches are approximately 5 centimeters distal to the acromion. Okay. When we talk about proximal humerus fractures, we of course want to talk about classification systems. The best classification systems are have good reliability, both intra and inter-observer reliability. They communicate the severity of the fracture, and ideally they would have some sort of, they would be able to lean you towards certain treatment protocols, treatment algorithms, and give an idea of the prognosis. So the most common one that we use is in NEAR classification. It's actually survived decades and decades. And this classification system is classified according to parts, right? So again, we talked about parts: greater tuberosity, lesser tuberosity, humeral head, and the shaft. Okay, so up to 4 parts. A part is defined as 45 degrees of angulation or greater than 1 centimeter displacement. The greater tuberosity has classically been had a less smaller threshold. Now, admittedly, when Neer wrote this, he didn't have these exact criteria. Actually, when he published in JBJS, the editor basically insisted that he create actual numbers to classify these parts. So, admittedly, these are actually kind of arbitrary numbers that we use, but we still use them regardless. Okay. So the one part's just non-displaced fractures whatsoever, okay? Two parts tend to be like either surgical neck or tuberosity. And then you go into more severe patterns, right? The 3-part, and then the 4-part being the most significant. The classic 4-part fracture is where you have complete displacement of the humeral head, okay? We've added on modifications to this, okay? So the valgus impacted. The reason why we do this is because there is a difference. So historically, in terms of prognostic value, the Neer classification, the 4-part fractures in a Neer classification carried the worst prognosis. This is because there's a high incidence of AVN, right? With the humeral head displaced, you are dissociating it from its blood supply from the arterial arteries from the circumflex arteries, right? So in his series, he had greater than 50% AVN, okay? However, with the valgus impacted, right, you're not necessarily separating the head from the rest of the shaft and its blood supply, you're just impacting it in place. And in many cases, you have intact medial cortical hinge. And so the blood supply is relatively preserved. And so the risk of AVN is not as great. We also expand this classification system to include special patterns, a head split, so articular split, impaction fractures, okay? And what's not included in here are also fractured dislocations. There's also the AO classification, but while we use the AO classification for many other periarticular fractures, we don't really use it that much in a proximal humerus. So just understand that it's there, but we don't really use it again. Okay. Now, the most important question is, which ones do we treat with surgery? Which ones do we not treat with surgery, right? And I think that's often a big question, and it's still a matter of debate even among seasoned trauma surgeons. The principles, though, have to do with I think it's more important to understand the principles that go into the decision making, and that will vary from patient to patient. Okay, so in my mind, when I'm deciding non-operative versus operative treatment, my decision is influenced by a patient's age, a patient's baseline function. Okay, and this has to do with like also not just chronological age, but physiologic age, the fracture pattern, and also the patient's bone quality, and with that, any associated habits and the risks of non-union. Okay, this is a study that I think you guys should know. Okay, we'll go into a little bit of detail right now. The reason for that is that it was published in JAMA, right? So anytime a surgical paper is, an orthopedic surgery paper is published in like JAMA or Lancet or New England Journal of Medicine, I think we should pay attention to it to understand not just like what it's saying, but also its benefits. So that way we can communicate with our non-surgical colleagues. So the proper study design was a pragmatic, multi-center randomized trial. Okay, basically what that means is that the treating surgeon basically decided whether or not a certain fracture pattern would be amenable to either non-operative or operative treatment, right? So if the surgeon thought, wow, this really needs operative treatment, they would not be included in that study. Whereas if they looked at it and said like, wow, it absolutely needs non-operative treatment, no surgery whatsoever, they also weren't included. So it was really up to the treating surgeon to decide whether a fracture could be included in the study to be randomized into either group. Okay, there wasn't really strict criteria. And while they used a Neer classification, they also didn't really adhere as much to that 1 centimeter, 45 degrees angulation. They recruited 250 patients and 109 received surgery, and there was some crossover. The result of this was that there was no difference in functional outcome scores, complications, mortality. Now remember, they looked at all age groups, right? Even though the average age was 66 years old, they included everyone, right? From 16 to however old, all right? So even when they broke it down to patients under 65, so technically young patients, quote unquote young patients, and old patients, there was still no difference. Okay, but does that mean that then we should, since there's no benefit in surgery, should we just be treating all of these non-operatively? Well, I think you have to go back into the study design and critique it. So this is a pragmatic study design, right? again, this could be open to some sort of bias, selection bias. Okay. The other thing to note is that among the 109 surgeries that were performed, it was split among 66 surgeons. So over a 2.5-year period, on average, surgeons are doing 1.6 of these surgeries. So you have a very heterogeneous treatment protocol. Okay, this is also split among 30 centers, right? So again, on average, like three of these fractures per center were included in the study design. Okay, also 18% were performed by a resident or fellow. Now they did say that the surgeon was in the room or available, but 18% were performed by a trainee. Okay, and there's also heterogeneous operative treatments, right? They included, while most were consisted of open reduction traumatic fixation, they also included arthroplasty, they also included intramedullary nailing. So we know that these can also have an effect on the patient's outcome scores as well, depending on your indications, depending on the fracture pattern. So while this study had a pretty robust statistics, there were some serious flaws in the study design. And what my takeaway from this is that it's another data point, but it doesn't mean that non-operative treatments are equivalent for all proximal humerus fractures. So in my mind, not that helpful for clinical decision making, especially when we get to certain patterns. So for me, when I'm thinking about patients who benefit from non-operative treatment versus operative, these are the patients who are elderly, the ones who are low demand, the ones who have simple patterns like minimally displaced, mildly displaced, or like a 2-part fracture, or like a mildly displaced 3-part fracture. Patients with osteoporosis where I know fracture fixation is going to fail, okay? Or also those who are also very sick who can't tolerate an operation. Also patients with alcohol abuse. Remember I said that bone quality does matter, and patients we know who have a history of alcoholism have poor bone quality, right? So their ability to actually heal that fracture is quite low, or even to have the fixation hold. In terms of operative treatment, I think about more for younger patients, those who are active patients, okay? And as well as complex patterns, right? So these are the bad 3-part, 4-part fractures, right? These are the dislocations, articular splits, open fractures, where even if they healed in that position, they're just not gonna do well. In terms of operative treatment, we have various options. So again, we can split it into ORIF versus arthroplasty, okay? And among arthroplasty, we can think about a hemiarthroplasty or even a total shoulder if they have pre-existing arthritis, or a reverse shoulder in more recent literature, okay? Again, my decision-making, I have various factors that go into that decision-making. So for me, age, right? So with increasing age, I'm leaning more towards arthroplasty, right? If you have a 30-year-old with a 3-part proximal humerus fracture versus like a 70, 80-year-old, right? It's going to change my treatment algorithm, okay? Fracture severity as well, right? So if I have like a 50-year-old with like a 2-part fracture, okay, that's displaced, versus like a 50-year-old with a 60-year-old with like a blasted 4-part fracture with a lot of articular impaction, right? I'm going to lean more towards the arthroplasty direction. Also, and if a patient is, even if he's 50, but very highly active, okay, then I may still lean more towards ORIF versus arthroplasty. Okay, so I'm taking all these patient factors as well as fracture patterns into account when I'm making these decisions. Okay. In terms of thinking about operative treatment, we should talk about approaches briefly. Okay, so there are 2 types of approaches that you should be aware of. One is a deltoid split. Okay, the advantage, so basically you're splitting in line with the deltoid fibers, and this gives you direct access to the greater tuberosity and as well as the surgical neck. It's a less invasive approach, but it has obvious disadvantages, right? It has less access to the humeral head. In complex fractures, especially if you need to get the humeral head, you need to see the articular surface, like sort of like splits, dislocations, you really can't get there, okay? You can't convert to arthroplasty procedure, and there's a risk of axillary nerve injury. Remember I said the axillary nerve is on average 5 centimeters distal to the acromion. Okay. The second approach is a deltopectoral approach, and this is the approach I think almost all of you are familiar with in working on a sports service. This is going to be your workhorse for most of the proximal humerus fractures you see when you're in service. You can do open reduction fixation as well as arthroplasty, and it's extensile, right? So if you have a shaft fracture, you can extend this into an anterolateral approach distally. A disadvantage is that it's more invasive than a deltoid split. And in some series, there's a question of higher rate of AVN. But it's hard to tease out because while it is a more invasive approach and you are doing more soft tissue stripping and you are affecting the biology more, Also, these tend to be used more for the complex patterns, which may be more predisposed to AVN to begin with, whether or not you use it through a deltoid split versus deltopectoral approach. Okay. So here's a case of mine. This is a 50-year-old woman. She was actually transferred from 3 hours away because the outside surgeon didn't know what to do. These are her injury films on presentation. What do you guys think? So it involves greater tuberosity, probably lesser tuberosity as well over here in the humeral shaft. So maybe a 3-part fracture, possibly a 4-part, but it's actually not that displaced. Do you think she needs operative treatment? Just think about that for a second. So if she had come into the ER, she was a local patient, I could have made the argument that actually you probably don't need surgery. Okay, that if the greater tuberosity heals where it is and the head heals over the shaft, she could probably do okay. Okay, but since she came over 3 hours and insisted, we went ahead with open reductional fixation. The operative sequence is as follows, right? Do you want to start with your approach? For me, I did a deltopectoral approach because I could actually access all the fragments. You want to take your dissection down to identify those fracture fragments. What I do first is actually tag the rotator cuff. And this goes back to my original statement when I went over anatomy, right? The fracture behaves based on the soft tissue attachments. But you can actually use those soft tissue attachments to your advantage. By tagging them, you can start to control all the parts, right? You can control the greater tuberosity piece, right? You can control the lesser tuberosity piece, okay? But also, I use them to help reinforce the repair. Oftentimes, there's a lot of combination, or in the more elderly patients, right, the bone quality may not be as good, actually, as your soft tissue attachments. So I'm going to use these, use the rotator cuff to help augment my fixation. Just like any other fracture, right, you want to reduce the fragments. You want to hold the reduction in place with K-wires, get some provisional fixation. You want to then proceed to definitive plate fixation. And then for me, I reinforce the repair by fixing the rotator cuff through the sutures to the plate. And then you want to do your closure. So this is sort of our sequence with her, right? I'm using a cob to reduce the humeral head over the humeral shaft, okay? I'm holding in place with K-wires, multiple K-wires, right? I'm checking to make sure that my alignment's reasonable, right? Remember your neck shaft angle is 135 degrees, okay? Checking on the lateral 2 to make sure I'm not tipping into some sort of deformity, okay? I select my plate, and it's important to note that you want your plate to sit 5 to 8 millimeters distal to the greater tuberosity. The reason for this is because you don't want to create impingement of the plate, okay? You don't want to create subacromial impingement, okay? These are my home run screws, right? These are the screws that are right along the calcar. These are really important. And again, I'm checking on multiple around the world views to make sure that none of my screws are proud, and you can be easily fooled when you're putting the screws in because the bone is so soft, they could easily get into the joint, okay? One of the main issues with these, even in young patients, is the amount of, is the quality of the bone and the amount of fixation that you can get, right? So if you have a fracture line in the anatomical neck, all right, you can imagine that while these screws are pretty long, mid-40s, right, only like 25% of the threads, more or less, are actually getting into the humeral head. So you don't actually get all that much fixation into the anatomical head where you get good bone. Oftentimes, especially in valgus impacted fracture, there may be a bone void or comminution over here, okay? So fixation failures, screw cutout are concerns in any of these fracture patterns, even if they're not elderly. So what can we do? So there are a number of things that have been described. Okay, one that Dr. Kannemir actually likes a lot is the fibular strut allograft. In fact, he just had that, had a case like that, where you actually use a fibular strut to help keep the humeral head elevated, okay, and keep it from collapsing down. Okay, you basically position it underneath the humeral head, and you secure it to the shaft, and you actually put screws. You can put screws through the fibular strut into the humeral head, and this provides extra points of fixation to help hold your humeral head and your reduction in place. You've also described using PMMA cement, similar to what we do in the femoral head, all right, with elderly hip fractures to prevent screw cutout. Okay. This is another case of mine. It's 63-year-old right-hand dominant woman, multiple medical problems, sustaining ground level fall. Okay. You can see it's proximal humerus fracture, but it's not just that, it's actually dislocated. Okay, here's a humeral head sitting anteriorly. So what sort of treatment options are you going to do? What are you thinking in your head? right? So pretty severe fracture, a 4-part fracture, okay? This is a 3D CT scan, okay? It's of the anatomical neck. So what do you think our outcome is gonna be with non-op treatment? It's gonna suck, right? You're gonna operate on this, right? You can't just leave your head dislocated. But in terms of your choices, ORIF versus arthroplasty, which one do you think would fare better? In this case, because it's of the anatomical neck and it's a dislocation on top of a 4-part fracture, she probably has a very high rate of AVN, right? So even if you get the fixation perfectly, the head is probably not going to survive. So for her, we decided to go ahead with a reverse shoulder arthroplasty, okay? Now, among the choices, classically, we use hemi-arthroplasty, but more recent literature, we've explored the reverse shoulder arthroplasty. This is one recent systematic review in JOT, which showed that the reverse shoulder actually has improved forward elevation, but decreased external rotation than hemi-arthroplasty. However, hemi-arthroplasty had higher rates of superior migration and revision. Okay, one of the issues with these fractures is fixation of the tuberosity fragments, all right, as well as resorption of those fragments. So in a reverse shoulder, we try to fix the tuberosities in place, but these may not always hold, and as a result, you have decreased external rotation.